Hello, everybody. My name is Thomas Gregory, and I am a clinical pharmacy specialist in pain and palliative care at Cox Health in Springfield, Missouri. And I'd like to welcome you to today's Pain Week Premiere, which we are offering 2 hours of pain management CE/CME hours. This is being provided by Global Education Group today. To our Pain Week audience, for your CME certificates, you will be sent the link by the middle of next week. Just click on the link, complete the form and the evaluation, and then you can download, print, and save your certificate right there. To send in questions during the webinar, click on the Q&A button on the bottom of the screen and type your questions in. Pain Week Digital All Access is an online library with over 100 hours of sessions from the live Pain Week National Conference and digital offerings that you can watch anytime, anywhere. Plus, every session is certified for credit. Pain Week is currently running a special offer. To save $100 off the registration price, go to painweek.org or click on the link in the chat box below and use the code PWP when registering. Or you can use that same code for our Pain Week 2022 conference in Las Vegas next year for one of our Pain Week Plus packages, which combines both the conference and the digital all access. This discount cannot be combined with other discounts, though. Pain Week Digital All Access will be available for viewing in October. If you would like to support us on LinkedIn, Facebook, Twitter, or Instagram, search for Pain Week, all one word. We appreciate your support. Webinars like these cannot be sustained without support from the health sciences industry. We'd like to thank Veritas Pharma, Inc. for their support for this Pain Week premiere. Our first presenter is Dr. Michael Botros. Dr. Botros is the Clinical Operations and Medical Director for Pain Services at the Keck School of Medicine of the University of Southern California, Los Angeles. His presentation is Apocalypse Now or Later, Chronic Pain After COVID-19. Please join me in welcoming Dr. Botros.
Thanks for having me. I'm going to be sharing my screen in just a second here, so I am going to take this opportunity to do that. Wonderful. Hopefully everyone is able to see my screen, and if you aren't, somebody will let me know. So I appreciate the warm introduction. I'm going to be talking to you this evening about COVID-19. Obviously, this is something very near and dear to all of us as we're facing the repercussions of it, and we'll be continuing to see these repercussions for quite some time. I'm based over in Los Angeles, and what we'll be talking a little bit about today is, and just to clarify, I have no disclosures, but what I hope that everyone can get out of this lecture today in terms of learning objectives is, what's the reported pathophysiology associated with COVID-19? What are the potential risk factors for the development of long COVID-19? And this is important to differentiate between acute COVID infection and long COVID symptoms, which we're going to differentiate between the two. And then what are some of the potential treatment options for long COVID-19? What are some of the things that are being studied right now? This is an ongoing investigation of sorts. So a lot of the stuff that you're going to be seeing in this presentation was just recently published, and there's going to be a deluge of more information coming in, on a daily basis. So what you're getting today is the most up-to-date information. If anybody has any questions, I'm happy to take them in the Q&A session later on this evening. So a little bit of the outline that we're going to talk about today. What is COVID-19 in terms of its pathophysiology, and then we're going to talk a little bit about the clinical features of acute COVID-19, because to really get a good understanding of long COVID, you really have to understand acute COVID. So we're going to talk a little bit about what we see in acute COVID, what's the treatment option for acute COVID, and then we'll talk a little bit about long COVID. What's the terminology, the risk factors, how does it affect certain organs, what are the treatment options, and then we'll conclude. So a little bit about the timeline. What we know so far is that December 8th of 2019, the first patient developed symptoms of coronavirus in Wuhan. And on December 31st, it was China that alerted the WHO about several pneumonia cases that started popping up in that region of the world. So subsequently, the very next day on January 1st, 2020, the Wuhan wholesale seafood market had shut down. And a week later was the first identification of COVID-19, this novel coronavirus. And then subsequent to that, January 11th was the first death recorded in China. And then the first case outside of China was reported just 2 days later from that first death on January 13th. And that first case was actually reported in Thailand. And then Wuhan was then placed under quarantine. And then January 29th, the death toll had climbed up to 132 with 6,000 new cases reported. And everything that you see on these slides, you'll be able to get the references on the bottom of your screen individually. So that way you can go more in depth if you're interested in. So then, subsequent to that, you started to see the spread across the world in this pandemic-like fashion. So first in the Western Pacific, as you see in the orange there in February, and then you start seeing it in Europe, especially hard-hit Italy in March, with those red bars. And then it took off into the Americas with the yellow bars, and then after that, it kind of started growing in May with the blue bars, as you can see, in terms of the development of the pathophysiology and the process of the pandemic. So what's going on with the pathophys? So the SARS-CoV-2 virus targets cells specifically through the spike protein, the S protein. And what the spike protein does is it binds to the ACE2 receptor, the angiotensin converting enzyme 2 receptor. And what ends up happening is that in the host cell, there is an enzyme called the serine protease type 2 transmembrane serine protease. It's a mouthful, I know. But basically, it's the TMPR SS2. And what that does is it cleaves the ACE2 and then it activates the S protein. And so that's when you start getting replication in the cell. So the reason why we're going through this is so you get a better appreciation of what are the different targets that people are investigating in terms of either prevention or treatment options for COVID-19. In the early stage, the viral copy numbers can be pretty high in the lower respiratory tract. And that's essentially because there's a lot of ACE2 receptors and cells in that area of the body, that and the kidneys, and that's why they're most affected. And so you get this massive inflammatory cascade and signaling molecules. So you get activation, T lymphocytes, monocytes, and neutrophils, and then you get a cytokine enhanced response. And so this inflammatory response is what tends to promote the symptoms that we're seeing in patients. And then in the later stage, what ends up happening, especially in the lungs, is that the lungs get filled with pulmonary edema, and they fill those alveolar spaces, and then you get hyaline membrane formation. And so that's why a lot of the symptoms that we see, especially in early phase COVID, is very similar to ARDS, or acute respiratory distress syndrome. And that actually plays a role into some of the methods that we use for treating acute COVID-19. Because first and foremost, I'm an anesthesiologist and then also a pain physician as well. So critical care is in my domain. So what are the clinical features associated with acute COVID-19? Well, we'll start with age. So age is definitely a major risk factor, and what we see is definitely associated with different stages of age. So in people who are less than 50 years of age, and in more so in patients who are less than 10 years of age, you tend to be asymptomatic, but in people less than 50, they may have mild disease. So they could have fever, fatigue, dry cough. You may find ground glass opacities on imaging, and they may develop a pneumonia. And typically, this is not necessarily the Delta variant, which changes things, and it's more acute in terms of onset. But it's typically a 5-day incubation period. Within 8 days, you start noticing these clinical features, the fever and the fatigue. If it in 14% of patients, and more likely in patients who are greater than 60 years of age, you'll develop dyspnea, and especially when you have coexisting illnesses, which we'll talk a little bit more in depth in just a minute, you may need ICU care. And then in less than 5% of patients, and again, more likely in the older patient population, greater than 68 years of age, at about 16 days out, within 12 to 20 days of the onset of symptoms, they have more clear ARDS-like symptoms. They may have an acute cardiac injury, and they may develop multi-organ failure. I would be remiss if I didn't necessarily talk about MISC in children. So for those of you who are unfamiliar, multi-system inflammatory syndrome is a condition that we're seeing specifically in children, and it's termed MISC. This clinical scenario started appearing in late March. So you can see that as more and more adults, along with children, started developing COVID-19, that the first symptoms of MISC started appearing. And this was data out of London in the UK. And you can see how quickly it took off. So what is MISC? Essentially, it's a constellation of symptoms associated with severe clinical features in young kids. And it's very similar to Kawasaki syndrome. And so some of the things that we see in these patients are almost 100% of patients will have a fever of some sort. An overwhelming majority of kids develop gastrointestinal symptoms. So they'll present with abdominal pain and diarrhea and vomiting episodes. So this is slightly different than what we're seeing in the adult patient population, where we tend to see more respiratory issues early on in the onset of the disease. A lot of these kids will develop conjunctivitis, and they may develop cheilitis. Very rarely do you actually get respiratory symptoms. So it's really, like I said, the inverse of what we're seeing in the adult patient population. Some kids will develop a headache and dizziness, but a lot of kids develop rash. And that's, one of those high hallmark features that we talk about, especially when we talk about Kawasaki disease. So that's why we're seeing this in this specific patient population. Let's go back to the traditional adult population. So what are the risk factors for developing acute COVID-19? And what's interesting is that these risk factors associated with acute COVID-19 are not necessarily the same risk factors for developing long COVID-19. So we got to differentiate between acute and long COVID. So for acute COVID-19, older age, male sex, non-white ethnicity. And again, non-white ethnicity may be due to comorbidities, but it also might be due to access to care. So we have to be careful about when we talk about these risk factors, what are these predisposing reasons for the risk factors, right? Pre-existing disability, and then pre-existing comorbidities. And the big ones for acute onset is obesity, cardiovascular disease, respiratory disease, and hypertension. So what do we do when we have a patient in the ICU with acute COVID-19? The biggest thing and the first step in care, obviously, is supportive care and respiratory support. And so the best practices right now are what we do for ARDS patients. More than 75% of patients with COVID-19 will require some form of supplemental oxygen. So if they don't necessarily respond to conventional oxygen therapy, they move on to a heated high flow nasal cannula. And then if you need invasive mechanical ventilation, what we do is we actually try to develop a lung protective ventilation strategy for these patients. So we try to keep the tidal volumes pretty low at about 4 to 8 milliliters per kilogram predicted body weight. And we try to keep the plateau pressures on the ventilator less than 30 millimeters of mercury. And this is essentially what we're doing with ARDS type patients. So what's really interesting is this question about when to intubate, right? So especially early on when the pandemic had first started, a lot of people were opting for intubation earlier. And I'm going to be showing you some really up-to-date pieces of literature in just a second, in the next couple of slides, that may be changing how we approach intubation for these patients. So many patients may be hypoxemic, but present with a normal work of breathing. So why would you want to intubate earlier for these patients? The biggest benefit to early intubation is that you actually have a more controlled process, because there's a logistical challenges to intubating, right? You have to have the appropriate personnel involved, an anesthesia provider, or a person who in the critical care unit may be well-versed in intubation. Again, you want to be doing this in an airborne isolation room. You got to don your PPE when you're doing this, because this is obviously a high-risk situation clinically. So you can understand why doing it earlier allows for a more controlled process. However, hypoxemia without respiratory distress is becoming more evident in terms of its tolerability, and patients could actually do well without mechanical ventilation. So what we may be doing is, unfortunately, treating patients with mechanical ventilation unnecessarily, which obviously has its own complications, like, for example, ventilator-associated pneumonias and whatnot. So this was just published about a month or two ago, and this was published in Critical Care. This is a meta-analysis looking at non-randomized cohort studies. So they looked at 12 studies, almost 9,000 critically ill patients with COVID-19, no statistical detectable difference in mortality between patients who underwent early intubation versus late intubation. This is huge, right? So the timing of intubation probably has no effect on the mortality or morbidity of these critically ill patients. And so it may justify a more wait and see approach, which could lead to fewer intubations, and therefore guidelines may need to be updated. Again, this was just published. And again, like I said, it's a controversial topic, but we need to bring it up when we're talking about COVID-19 treatment. What about pharmacological treatment? So these are the classes of drugs that are being evaluated or at least being developed to manage COVID-19. So we've got 6 main categories. We've got the antivirals like remdesivir. We have antibodies like convalescent plasma. We have anti-inflammatory agents like dexamethasone, targeted immunomodulatory therapies, anticoagulants like heparin, and the antifibrotics like tyrosine kinase inhibitors. So this is a schematic that sort of shows where along the spectrum these different drug classes are targeting. And if you can see my cursor here, we'll start on the left upper corner. So you can see how different drugs like recombinant human ACE2 could bind to the virus and therefore inhibit the cell from binding. Here is where chloroquine or hydroxychloroquine would be purported to work. Fusion inhibitors like HR2P or EK1C4 can inhibit the fusion of the membrane of the virus onto the host cell. And then obviously you have a number of antivirals that are affecting the reproduction of the virus within the cell, like remdesivir, lopanavir. And then we have to talk about the release of the cell, of the virus outside of the cell. So that's where antibodies can be helpful. So things like sarilumab may bind to IL-6 specifically or inhibit IL-6 signaling. It's trying to break that massive cytokine inflammatory response. Again, dexamethasone inhibits those inflammatory cytokines. And that way it can help with some of the clinical features that we're seeing. So when we're talking about pharmacological treatment for acute COVID-19, it's important to understand that some of these drugs and these different modalities may have different efficacies based on where you are in the stage of the illness and the virus. And so that's why maybe using an antiviral in the midst of an inflammatory response may not necessarily provide the same level of efficacy as earlier on in the infection stage. So timing is really important, and we're still trying to figure that out. Like I said, viral inhibition would be most efficacious early on, but then in patients who are hospitalized and are having disease progression, you might want to start providing immunomodulatory agents or at least anticoagulation medications because of the high risks for coagulation issues and thromboembolic complications. So now let's move on to long COVID-19. That was acute COVID-19. So long COVID-19 has to be defined, and it really is a bit of a dirty mess right now, because we typically think of acute COVID-19 as lasting about 4 weeks from the onset of symptoms. And then we talk about post-acute COVID-19 as symptoms that are either continuing, delayed, or long-term after 4 weeks from the onset of symptoms, as you can see in this graph. And there are phases of this post-acute COVID-19, right? There's the subacute phase, and then there's the chronic post-COVID-19 phase. And there's a variety of different clinical features associated with these things. When we talk about creating delineations for vocabulary for long COVID-19, a lot of organizations are using the NICE guidelines, which are from the UK. They basically stand for the National Institute for Health and Care Excellence. And so, as I said, that acute COVID phase is about 4 weeks from the onset of symptoms. Post-acute COVID-19 is from 4 to 12 weeks. And then anything after 12 weeks is post-COVID-19, also known as long COVID syndrome. So what are the risk factors for developing long COVID? Remember, way back we talked about those acute COVID risk factors. So age is the same thing. Age is a long COVID risk factor. Anyone greater than 50 years of age definitely has the greatest odds ratio. The number of pre-existing medical conditions has the greatest odds ratio of not returning to usual health. And some of these have higher risks than others, but a pretty big odds ratio: obesity, a psychiatric condition, an immunosuppressive condition, and or hypertension. And the more number of pre-existing medical conditions that you have, the more likely the odds ratio of you not returning to usual health. Patients who have a more severe acute phase would have a greater risk of transforming to long COVID. So if you've got more than 5 symptoms in your acute COVID phase, you're at a high risk of having long COVID symptoms. And some of the risk factors associated for acute COVID-19 don't translate to long COVID. So for example, long COVID symptoms are higher in women compared with men. But I had told you that acute COVID is higher in men than in women. The other thing is we got to be a little bit more specific about age, right? So we talked about age being greater than 50. But let's talk about people who are most affected by long COVID symptoms, right? So it turns out that critical age group of 35 to 49, they're the ones that are going to report that they're most affected by long COVID symptoms, followed by the 50 to 69 year group, and then greater than 70 year age group. So what do we see in long COVID-19 to be aware of? We're going to go through this on an organ system based level because that's the best. It's such a broad disease and it affects so many organs that it would be best to try to target this in a very specific way. So we'll go organ by organ based, and we'll start with the respiratory system since that's the one that's most affected by COVID. So a lot of patients will present with ARDS, like we talked about earlier. So then they develop these extensive bilateral diffuse alveolar damage. They'll have fibromyxoid exudates. They'll have desquamation of the pneumocytes. So it essentially causes a diffusion impairment. And these patients can start acting in the long term like a pulmonary fibrotic patient. And we think that some of the mechanisms obviously are associated with the spike S1 protein binding to the ACE2 receptor. But we think of the reason why they have this these features of a fibrotic patient is because of that post-ARDS fibrosis with the diffuse alveolar damage. So how do they do prognostically? 6 months after their infection, they still have a pulmonary function deficit. And they can have extensive diffuse impairment, and they can even have thrombosis. We had talked about the thromboembolic complications associated with this disease. So if you look at the data and you're talking about symptoms, if you look at the graph here on the left, we have 3 groups of patients. So patients during their hospitalization, the first group on the left needed just oxygen, patients in the middle needed CPAP, and then patients over on the right column on this side here needed invasive ventilation or intubation. And you can see that that a number of patients report breathlessness as a long COVID symptom, and that a higher proportion of patients who needed mechanical ventilation will continue to have coughing episodes. They'll report fatigue and definitely poor sleep quality. And if you look at the number of days post-discharge, you'll see that that issue of patient-reported breathlessness it can persist for quite some time. You can see that shortness of breath sort of numerical rating scale can be all over the place, and it can be pretty persistent and as high as 60 to 80 days, with a few reporting closer to the 100-day stage. So if you're following your patient who's got these symptoms of long COVID, should you be getting imaging, especially 3 months out, 6 months out? So this is some data that was, again, just recently published a couple of months ago about what these image findings, according to these imaging tools, show in COVID-19 survivors. So let's start with chest x-rays. Chest x-rays don't correlate. We've always been taught that, chest x-rays always lag behind clinical symptoms, right? So chest x-rays don't correlate with abnormal CT findings. Changes in chest x-ray findings are associated with recovery duration, but it's really of questionable efficacy to get a chest x-ray. So then let's talk about CT scans. So abnormal CT findings were detected in 71% of COVID-19 survivors. That's a pretty incredible statistic. A lot of unresolved lung tissue pathology had been shown, and that there is significant correlation between the CT findings and the disease severity. Lung ultrasound could be a good alternative option. It can accurately assess the resolution of residual lung tissue abnormalities. And so lung ultrasound findings can also correlate with the duration of COVID-19 symptoms and can be even done in home settings if the patient can't make it into a hospital and they're getting home care. And then finally, MRI. So the nice thing about MRI, it can be used to assess both lung as well as cardiac involvement. So 58% of patients who had recovered still had abnormal MRI findings, including myocardial edema and late gadolinium enhancement. And you can still see fibrosis and compromised right ventricular function, especially if you have that fibrotic picture with the lung tissue. You can understand that there's a lot of right heart strain that would be associated with these patients, something to think about when continuing treatment with them. So that leads us and segues into the cardiovascular system. Patients will present with microthrombosis, inflammation of the endothelial system, damage to capillaries, again, hypercoagulability with myocarditis and inflammation of the heart, AFib, a lot of dysrhythmias like SVT. And they present with an increased target to blood pool ratio, and you'll see a lot of capillary disturbance, again, impaired oxygen diffusion. We think, again, this is due to cytokine storm and then macrophage activating syndrome. So it causes changes to the endothelial cells and causes dysfunction. What's their prognosis? So 81% of COVID-19 patients will survive, but they'll continue to have ongoing subclinical inflammation of the heart, and it could put them at a higher risk of myocardial dysfunction and or sudden cardiac death. Hematologically, we touched on this several times. Thromboembolism is the main diagnosis. We find levels of high D-dimer and C-reactive proteins, increased biomarkers of inflammation. And prognostically, the question of how long these patients should be on anticoagulants is still being investigated. So jury's still out on that. When it comes to the urinary system, they will develop in the acute phase with acute kidney injury, and they may develop renal failure long-term. We find a declined GFR and kidney infarcts, and we think that this is due because of the high expression of ACE2 receptors in the kidneys. Remember, ACE2 is really concentrated in the lungs and in the kidneys, and then in other areas of the body. So there are high risks of mortality and morbidity with these patients. In the GI system, we find that a lot of these long COVID patients will present or continue to have hepatic and cholestatic liver injury, and they may have problems with their pancreas. And we talked about that in just a second with the next slide. But what we find is diffuse damage in the bowels. We'll have desquamation of enterocytes. We'll have bowel edema, small bowel dilatation, hemorrhage, necrosis. Again, the GI system has a lot of ACE2 receptors, and there is reported fecal or oral transmission, which is why some of these patients develop GI symptoms instead of lung issues initially. And we do see plasma cell and lymphocytic infiltration of the lamina propria of the intestinal tissues. So people can continue to have persistently elevated liver enzymes up to about 2 weeks after discharge. And it can take as much as 2 months for the liver function in these survivors to normalize, something to keep an eye on. What I find really interesting, and again, really disturbing, is what happens to the endocrine system in these long COVID patients. Because what we see in the acute phase is we see a lot of dysregulation of glucose control. Again, this could necessarily be due to a number of factors. Obviously, acute infection causes hyperglycemia. Also, the fact that we might be giving dexamethasone to these patients may be causing hyperglycemia. So they may be having hyperglycemia without outright diabetes mellitus. But these patients are now starting to develop new onset diabetic mellitus and starvation ketoacidosis. They have high levels of glucose. They have impaired glucose metabolism. Why? Because apparently what's going on with this autoimmune response is that beta islet cells in the pancreas are actually getting attacked. And so we may be seeing a new wave of basically type 1 diabetes due to autoimmune mediated cell death. And we may have a new wave of patients that we have to take care of with diabetes as a consequence of long COVID. And then neurologically, we have patients who have mood changes, cognitive difficulties. We'll talk a little bit more about that in just a second. Headache, fatigue, confusion, problems with attention. We think this may be due to hypoxic injury or microbleeds or just neuronal inflammation. And that's important when we talk about some of the treatment options. Could be due to blood vessel damage, impaired oxygen delivery, again, cytokine-mediated events, and even microglial damage in the brain, like what we see in patients with strokes and neuroinflammatory diseases. Over 40% of patients who survive without any prior psychiatric conditions continue to report depression 90 days after recovery from COVID-19. And 70% of them don't receive treatment for depression. It's important to be asking these types of questions to your patients when you're following up with them. They may not necessarily readily deliver that kind of information if you don't ask. So I think you get these slides. This is just a good sort of overview of the different organ systems involved in long COVID as a summary slide. So this is really interesting, okay? This was just published about a month ago. This is 1-year outcomes. A lot of people were waiting for this paper. And it was published in the Lancet, and it comes from China, 1-year outcomes of hospital survivors. Remember, this is hospital survivors. These aren't patients who basically stayed at home and tried to recover at home. So this was an ambidirectional cohort study, COVID-19 hospitalized COVID-19 survivors. They followed them at 6 months and at 12 months. And they interviewed them with questionnaires on symptoms, HRQOL or health-related quality of life, physical exam, 6-minute walking test, and then lab tests. And then they were matched for people who didn't ever get COVID, with age, sex, comorbidities, completed the same assessments. And their primary outcomes were symptoms, the MMRC or the Modified British Medical Research Council score, again, HRQOL, and then the ability to walk in 6 minutes. So this is a busy slide. I don't want you to focus on everything. I'm going to highlight a couple of things for you. The first thing I want to show you is that at 12 months, so 1 year from COVID, acute COVID infection, almost half of these patients are reporting at least one symptom. This is very important because as we see this surge with Delta, hopefully it's now starting to wane, but as we keep seeing these peaks, you're seeing more and more patients that are going to be having long COVID symptoms as far out as even a year. So I want to focus on a couple of these symptoms. The highest reported sequelae was fatigue or muscle weakness. People just feel fatigued even 1 year out. Number 2 was sleep difficulties. And then number 3 was hair loss. Number 4, joint pain. And it's important to distinguish these things because obviously these patients will be coming to you at 1 year to discuss or at least even up to 1 year to discuss treatment options for a lot of these things. And then if you look, pain or discomfort was the highest reported EQ5D5L questionnaire symptom in this cohort, and this is even up to 1 year. And then anxiety and depression was the second most. So these are things that we have to be aware of for our patients. I show this slide because I find it interesting. These are different cytokine levels in the acute phase, at discharge, at 6 months, and then at 12 months. So each box is a different cytokine. You have IL-1 beta all the way up on the top left, IL-12, TNF alpha is right here. In the middle, you've got IL-10 over here. Why is this important? It's important because it's showing us that these cytokine levels continue to be elevated at 6 months and at 12 months. And what's interesting is that these are the same cytokine levels that are implicated in chronic pain conditions. So these might, whether it's a chicken or egg phenomenon, we don't know yet, but we do know that that's part of the relationship between patients who have long COVID and chronic pain. So what about treatment options for long COVID? Again, referring to the UK National Institute for Health and Care Excellence guidelines, there are basic screening assessments for long COVID. And so if you have any patients as primary care providers or primary health care individuals that you want to assess for long COVID, you can use, there's a lot of different kinds of questionnaires. Here, obviously, because this is the UK guidelines, they talk about the Yorkshire Rehabilitation Screen or the C19YRS, but there's different validated questionnaires that you can use. In terms of laboratory tests, so what's interesting is that they question, they suggest chest x-rays. We talked about whether or not chest x-rays are necessarily indicated, but it could be an initial start. Pulmonary function tests are a little bit more sensitive and specific, and then the exercise stress test. Blood tests, liver function tests, TFT clotting profile, and then we can investigate inflammatory conditions like CRP and D-dimer. And so in terms of the rehabilitation model, they stratify it based on the severity of their long COVID symptoms. If they're mild symptoms, you could just surveil them at home and then use some telemedicine. If it's moderate, they suggest community therapy as well as telemedicine and regular follow-up. If it's severe, you'll need a multidisciplinary team with regular follow-up. So when we're talking about a multidisciplinary team, what are we talking about? Well, we'll start here with primary care in the lower part of the lower right part of this graph. So we want to ensure that these patients get early rehabilitation. So PT, OT, very important, patient education. And it's really important that these patients don't feel like they're the only ones suffering. So there's a number of patient advocacy groups that exist to talk to patients who have long COVID. Make sure that if they're developing symptoms that are associated with depression, PTSD, anxiety, that they see the appropriate people and or are connected with different patient advocacy groups. They may need to follow up with nephrologists because of the acute kidney injury to assess recovery of renal function. From a hematological perspective, we talked about how a lot of these patients are continuing to receive extended thromboprophylaxis to ensure that they don't get blood clots. In terms of lung function and cardiac function, it may be important to assess with things like PFTs, or echocardiogram as indicated. And then again, you want to screen for these symptoms: anxiety, depression, sleep disturbances, and cognitive impairment. What are some of the things that are being looked at for long COVID treatment options? Well, obviously, we have to realize that non-pharmacological strategies exist, right? Not everything is cured with a pill. So we got to make sure that, and we're going to do this organ system based. So this is treatment for the lungs, right? So for the lungs, breathing exercises, pulmonary rehab, very critical to try to get better outcomes with these patients. Again, we treat these patients like a pulmonary fibrosis patient for the reasons that we talked about earlier. So that's why antifibrotic therapies may be advantageous. From a cardiovascular perspective, we got to be mindful of cardiac arrhythmias, and acute coronary syndromes and angina in these patients. Again, there's a lot of stress on the heart, especially when the lungs are involved and you get right heart strain. So it may be that beta blockers are useful in the treatment of these manifestations for long COVID. Myocarditis typically resolves with time, but a systematic review is looking at immunomodulating therapy that could potentially enhance a faster recovery process. We talked about anticoagulants, again, using it to reduce the risks of hypercoagulability. How about cognition? So a lot of patients describe their symptoms of, I guess, cognitive impairment, for lack of a better term, as brain fog. And they compare it to chemo brain. So patients who are undergoing chemotherapy, they talk about the same kinds of symptoms. So the Mayo Clinic actually recommends strategies to manage chemo brain, including repeating exercises, tracking what creates deficits, stress relief, coping mechanisms. There are some medications like methylphenidate, donepezil, modafinil, and memantine that could be helpful in these patients. Again, remember, this is a new emerging disease. So the data is ongoing and it's really hard to get. I mean, a lot of this is treatment on the fly. And so you have to understand that these are what people are investigating right now. Interestingly, luteolin is a natural flavonoid, and it may alleviate cognitive impairment because what it does is it inhibits mast cell and microglial activation. But again, clinical trials are required. Antihistamines can be a possible treatment option. Think about it. We talked about the ACE2 receptor, right? And so a study is looking at cellular experiments to antagonize, using histamine 1 antagonists to try to inhibit the virus from entering ACE2 expressing cells. And so there are systematic reviews that suggest that histamine 1 and histamine 2 antagonists may be viable candidates for further clinical trials in COVID-19. And it's still questionable whether or not antihistamines have a role for treating long COVID-19. Antidepressants can help reduce the effects of long COVID. Interestingly, antidepressant use has been associated with reducing the risk of intubation or death in acute COVID-19, and that a meta-analysis of antidepressant drug use for depression has shown that antidepressants, including SNRIs and SSRIs, reduce peripheral inflammatory markers. Again, one of the hallmarks that we're seeing in patients with this condition. I want to bring up low-dose naltrexone. I'm not sure how many of you are familiar with low-dose naltrexone. In the pain management world, a large number of us are using low-dose naltrexone, which has been shown from Stanford to reduce microglial cell activation and inflammation in conditions like fibromyalgia and CRPS, or complex regional pain syndrome. Studies are still not necessarily, there are studies that still need to be performed to see whether or not it can help with long COVID, but I'm talking about it from an anecdotal perspective. Please don't take this as evidence-based, because again, it's emerging. But anecdotally, a number of people at USC in my pain division group, in terms of treating patients who have these long COVID symptoms, have had a significant response, a positive response in these symptoms, especially the neurological symptoms, using low-dose naltrexone for the same sort of reasons that we would use this in patients with fibromyalgia, for example, that neuronal inflammation. And so we typically use 4.5 milligrams BID, starting with 1 tablet in the morning for a week, and then going to BID dosing. Again, further studies need to be treated for specific long COVID-19, even though it is being used. Now, I'm going to show you a lot of different clinical trials. So what's nice is that I'm actually giving you the clinical trial, like clinicaltrials.gov number. So if you want to look this up to see what happens, like has it gotten finished and are the publications pending soon, feel free to do that. You have the reference right here. People are looking at using hyperbaric oxygen, montelukast, and dipirfenidine to treat respiratory conditions. They're looking at breathing exercises, even singing, to assess improvement in breathing abnormalities for people who have long COVID. There's a trial looking at an 8-week exercise program to treat patients with long COVID-19 and fatigue. What's interesting is that vitamin C has been shown to be useful in treating fatigue in long COVID-19, in acute COVID-19 symptoms. So the question is whether or not it could be useful in treating fatigue in long COVID. And so there's a trial, the Lovett COVID trial is looking at high-dose IV vitamin C in hospitalized patients with COVID-19. They're going to hopefully assess both acute and potentially long COVID symptoms. There are 2 trials looking at the effects of nicotinamide riboside. It's a dietary supplement. The idea here is that it's modulating the pro-inflammatory response, similar to the earlier dietary supplement we talked about. And then, interestingly, people are looking at probiotics as a way of trying to normalize the gut flora composition and to help try to reduce inflammation in patients with long COVID-19 who still have GI symptoms. So for a lot of patients, what I want you to get out of this is that full recovery from COVID-19 may take more than 1 year. And that raises really important issues for health services and for research. So only 0.4% of patients who had COVID-19 said that they participated in a professional rehab program. That's a big deal. I'm worried about what the long-term implications of this are. The reason for such a low use is unclear, but it could be poor recognition of long COVID. And that's hopefully why this talk could be more helpful in at least bringing awareness about these things with your patients, and especially with a lack of clear referral pathways. And then the effect of long COVID on mental health still needs to be studied. Like we said, at 12 months and at 6 months, a large number of these survivors continue to have anxiety and depression, and that these things need to be studied in terms of an appropriate public health plan. How are we going to treat persistent long COVID-19 symptoms, especially 1 year out, 2 years out, from a public health perspective? And how are insurers going to cover rehab for these patients? And then let's talk about access to care and disparities and inequities. How are different ethnic groups going to be at a disadvantage because of predisposed problems in terms of healthcare equity? So these are a lot of things to be thinking about. And I'm going to end it there. but I'm happy to entertain questions in the Q&A session. Hopefully this was helpful.
We'll go ahead and get into non-opioid analgesics. Here's my title and affiliations. As I mentioned, my name is Thomas Gregory, and I wear two hats, like probably many of you. I work in pain and palliative care, and I also work in the emergency department. So I have lots of things between acute, chronic, and everything in between. I have no disclosures. Here's my hope for the rest of the evening's presentations. I want to focus specifically on everything other than opioids. So in order to do that, we're first going to have to figure out where these non-opioids work in the entirety of the pain pathway. We need to figure out what the differences are between, for example, non-steroidals and steroids and antidepressants. We're going to look at guidelines, and we're also going to look at recommendations and what package inserts say as far as FDA approved indications. And then we're going to look at risks and benefits, specifically when we're looking at a patient case. As many of you are aware, there are a lot of different parts to the pain pathway. There's transduction, transmission, perception, and modulation. So if you just take a look at your diagram here, nociception, it starts with transduction. So that's that cutaneous, subcutaneous route. So then so that pain signal travels through the dorsal root ganglion and the spinal cord, travels up through into the central nervous system where it's processed in the brain. That's the transmission, which is in red here, and perception, which is there is no pain without the brain, as a smart colleague of mine put it, because pain is only the perception of what those stimuli and what those pain signals being sent to the brain are. And that tells us that this is some kind of a noxious stimuli or a painful response. And finally, we have to turn that off. So the blue parts here actually are the descending pathways, which would cause modulation or the turn off when it comes to the pain signal that was received from the periphery. Where do they work? Well, all of these non-opioids work at a lot of different places. They work at the site of transmission, they work at transduction, they work at modulation, they work at perception, they work basically everywhere. These are just a few of the different types of channels and a few of the different, excuse me, and a few of the different neurotransmitters that are involved in this process. And as you can see, this is just a small sampling, but there's a lot of them. I'm not going to spend tons and tons of time on all of these, but I'm going to try to highlight the ones I feel are the most appropriate based on clinical practice and likelihood of use in your patient populations. So acetaminophen is the first one I bring up. It starts with A. It's generally considered to be in its own category, but there is some thought that it might be a partial COX inhibitor. Now, about 7 years ago or so, the FDA mandated that all prescription products had to cap the amount of acetaminophen in any combination products, cough and cold, opioid with acetaminophen, et cetera, at 325 milligrams. But really, who says how much acetaminophen is appropriate versus inappropriate? Well, if you look at the FDA, they actually said that it should be around 3250 in terms of that's where it should be considered to be capped off. But Johnson & Johnson, the makers of brand name Tylenol, they actually say you should only get to 3 grams in a day. When Grandpa Zimba taught me years and years ago, it was 4 grams. And I always used the stance of if it's around 2 grams or so, if you have a patient with liver dysfunction. So really, the liver is going to drive what you are and are not able to do. Again, children are going to be dosed based on a milligram per kilogram basis, and then adults in general between 325 and 650 milligrams per dose. The biggest concern that we run into is unintentional overdoses. So you have patients that are either on those combination products, or since we're getting ready to start cough and cold and flu season, everybody goes to the pharmacy. Everybody says, oh, well, I need this cough and cold product. Oh, well, I'm taking hydrocodone and acetaminophen. They're probably fine, right? The problem is if they're taking both the cough and cold preparations with their hydrocodone with acetaminophen, they could be going way above 4 grams a day, especially if they're not taking that cough and cold preparation correctly. The problem with that over a long period of time, as you can notice here, is that acetaminophen has to be eliminated or removed from the body. The problem is when you have maximized or saturated this glucuronidation pathway, you actually turn into the cytochrome P450 pathway, which makes this thing here called NAPQI, N-A-P-Q-I. And APQI is actually an hepatotoxic substance. It increases oxidative stress and eventually can cause liver dysfunction and damage. When it comes to inflammatory pain, probably the two biggest things would be steroids, corticosteroids or glucocorticoids, and non-steroidal anti-inflammatories. I have a couple of the non-steroidals listed out here. I really have no preference as to which one someone uses. It should be based on the pharmacology of the drug. Ibuprofen generally is between every 6 and every 8 hours. Celecoxib can be dosed once daily, and it really is going to depend on the patient specific. And then there's a couple other things with respect to COX-1 and COX-2, which we'll talk about. So as I just mentioned, there are a number of different non-steroidals, but really it's important to understand how did we get here? How did we recognize that COX can be inhibited and cause a decrease in inflammation? We found that there are 2 specific COX enzymes that we're looking at. The first one is really more from a homeostasis type of renal homeostasis and GI tract type of maintenance. And then there's COX-2, which really this is for inflammation, but also platelet aggregation. That's going to come up here in a little while. People that I would probably try to avoid using non-steroidals in would be those that are on anticoagulation, whether that be warfarin or if they're on one of the new DOACs or NOACs, such as Eliquis or Xarelto, any of those. And anybody that's pregnant should avoid non-steroidals as well. In normal physiology, not pathophys, but in physiology, arachidonic acid goes through either COX-1s on this side and COX-2s on this side. COX-1s, you actually have thromboxane, which causes vasoconstriction. And actually, when you're giving a patient aspirin, you're trying to knock out this COX-1 right here to decrease platelet aggregation at the platelet itself. Now, for COX-2, you have pain and inflammation from prostaglandin E2 and I2. This is really what we're trying to get this is really the target when we are using a non-steroidal. Ibuprofen, celecoxib, it really makes no difference. We're really just trying to work on this COX-2 in order to decrease pain, decrease inflammation. Because if arachidonic acid through COX-2 at the joint level is causing through PGE2 and PGI2, it causes pain and inflammation. So we're trying to use those non-steroidals to decrease that. Now, this platelet aggregation on the endothelium, we're going to talk about, and I think it's probably going to be very apparent as to why very soon. How many of you remember rofecoxib? How many of you remember valdecoxib back when those were still available and on the market? Because the only current COX-2 inhibitor we have is celecoxib in the United States. Well, they removed rofecoxib from the market back in 2004 because of the Vigor trial, because they said basically patients that took 50 milligrams of rofecoxib daily were at a 2 times increased risk of having myocardial infarction. So that's why that got pulled from the market. So if you look at your semi-selective versus your selective agents, here's your COX-2 specific. And they did some studies that looked at COX-2s compared to non-steroidals to see, is there an increased risk of cardiovascular events? Well, for rofecoxib and valdecoxib, that was true. The celecoxib, the initial data really didn't have a ton of information that tied it to say that it was statistically significant. They're still looking at some of those data, but in general, celecoxib, because it has such a low affinity to bind to the endothelium and cause this inhibition of COX-2 at the endothelium level, it's less likely that celecoxib is going to cause it, at least with our current information right now. One of the semi-selectives that I like to bring up here is meloxicam. Rationale behind that is because you have a really good marriage between, it has COX-1 and it does have COX-2, but it has less of the COX-1, so decreased risk of GI complications, decreased risk of renal complications, but also a decreased risk in of cardiovascular complications from COX-2, as we just kind of talked about. And I told you, here's aspirin over here, looking at, it does have those cardioprotective effects at the level of the platelet, but because you have that COX-1 non-specific binding, you do have that increased risk of GI effects. What are some things that we can give to a patient, or that we can provide for a patient that uses non-steroidals on a regular basis? The biggest one's probably going to be proton pump inhibitors. That right there, honestly, is probably the biggest one and the most appropriate. That's actually what's still recommended by the Geriatric Society as well. H2 blockers can be used, but keep in mind, proton pump inhibitors don't come without their own risk factors, such as increased risk of hypomagnesemia, increased risk of fractures, increased risk of falls, increased risk of pneumonia, osteoporosis. I mean, I could just go on, but you get the point. Risk factors just in general for non-steroidal or related GI toxicity include those that are over 65. If you've already got a comorbidity such as rheumatoid arthritis or another inflammatory type of autoimmune disorder, if you're already on anticoagulants, again, aspirin or steroids by themselves. So I know I do get a question sometimes regarding, can you have a patient on a non-steroidal and a steroid at the same time? Well, the answer is it depends, because really you've got the corticosteroid that's going to be working at COX, at the level of COX inhibition as well on inflammation, but then you've got the non-steroidal. So if you're using the corticosteroid for pain control, I probably wouldn't combine it with the non-steroidal at that point, but we'll talk about that when we talk about steroids. This is just a meta-analysis looking at GI complications following patients that were on any type of non-steroidal. This looked at ibuprofen, celecoxib, did have the rofecoxib inhibitor as well. And in general, every COX non-specific NSAID increased the risk of GI complications. And those GI complications included bleeding, perforation, obstruction, and ulceration. The only one that really didn't, and again, it's not statistically significant since it's crossed the line, but is high-dose celecoxib. So basically, even COX-2 inhibitors can still cause some of those GI complications. Another one I run into, especially when I'm discussing with orthopedic surgeons, is the risk of NSAIDs that cause decrease in fracture healing. That's been a big concern for orthopedic surgeons for a number of years, and that actually stemmed from 4 studies that were interesting in their construct at the time back in the 70s and in the 80s. 3 of these trials were actually retrospective. They didn't even account for confounders like smoking, which we already know increases risks for fracture, non-healing, and non-union. And also, there was a single prospective trial that had 13 patients. So from that perspective, it makes me wonder what kind of data you're going to be using to apply to a patient. So they actually conducted 2 meta-analyses looking for any kind of literature, which they found no high quality literature, but they did find at least some literature to see whether non-steroidals actually did have an impact on fracture healing. It should be noted that opioids by themselves can cause immune function impairment. So that paired with a fracture could also lead to fracture non-healing as well. I just throw that out as a tangent. In the end, though, Journal Orthopedic Trauma actually came out and said that non-steroidals should be considered for inflammatory pain conditions, even in those patients with fractures. So that's why I have that there. If anyone wants to use that, please do. Again, I'd rather you have the information. What if you really just don't want to deal with these GI complications and all these other things, systemic complications? Topical nonsteroidals are a great option here. You have the gel, you have the patch, and again, you're bypassing the systemic circulation, you're bypassing first pass metabolism, you are absorbing a drug into the skin, and it's really getting to the site of action. So your upper extremities or your lower extremities, and it really just kind of depends on what type of pain the patient has. If it's localized to only the bilateral wrists or elbows, certainly going to be a lot easier than if you're trying to apply it to bilateral shoulders, for example. Again, these topical nonsteroidals still carry the same black box FDA warning about cardiovascular risk that every nonsteroidal does, but that's because that nonsteroidal was looked at in aggregate as an oral preparation. Even though this is being given topical, the company's probably not going to go back and try to remove that FDA black box warning with the trials and the data necessary to actually prove that they don't cause cardiovascular toxicities. Let's switch over to glucocorticoids. So here basically is how cortisol works, and it comes down through transcription. And if you'll notice, one of the things it causes a decrease in transcription for is COX-2. So as I mentioned, COX-2 is being affected by nonsteroidals and also by glucocorticoids. Again, these are really going to be used either orally, which can be for multiple different types of conditions. They've been used in MS. They've been used for acute other neurological conditions, been used COPD, for example, lots of routes of administration, oral, parenteral, interarticular for some of you providers that are actually doing these in the office. And I've just got a chart here that you can find this pretty much anywhere. And it just has the different potencies, and it shows which ones are much more likely to have mineralocorticoid, which is going to be the renal saltwater distribution type of potency, versus glucocorticoid, which is inflammatory in nature specifically. Also has to do with glucose metabolism. Things that I worry about with glucocorticoids long-term, especially if they're diabetic, because glucocorticoids can increase your blood sugars. They can also cause just significant swings in diabetics. Even if they're well controlled at baseline, probably just have them start checking their blood sugar a little more frequently while they're on the glucocorticoid, and even a couple of days after they stop the oral or the injections, just to make sure that their sugars stay within range. For those patients that have a psychiatric history, especially those with mania, that can actually potentiate and perpetuate mania. In heart failure, you actually retain sodium, again, because of that mineralocorticoid effect, increases risk of heart failure exacerbation. If you've got a patient, especially if you've got a patient over the age of 65, if you're going to be using a supratherapeutic dose, in other words, anything over about 7 to 8 milligrams as defined by the American College of Rheumatology a few years ago, of prednisone oral equivalents for more than 14 days, you'll need to taper. That prevents hypothalamic pituitary axis crash. So if you're going to go past 14 days, plan on a taper. You can do burst therapy, 5, 10 days, but especially if you've got a patient that's exquisitely sensitive to glucocorticoids, or if they've had a reaction in the past, you probably want to start thinking about a taper if you're exceeding 10 days. Also, those patients that are already immunocompromised, you have to be conscientious as well. Could you use topical glucocorticoids for pain? Keep in mind the skin is a barrier to absorption. The skin also in the stratum corneum contains lipid and hydrophilic regions, so it traps lipid soluble and water soluble. Here, I just have like the size of these specific ones, and really, when you're thinking about the lower, these drugs can get into the local area but the problem is when you're going to deliver prednisone, methylprednisolone, any of these, you're going to generally need to use iontophoresis or something else in order to penetrate deep enough, because the over-the-counter creams like hydrocortisones and such, they just don't penetrate sufficiently to reach deep tissues, joints, or bone. So if you are going to do a procedure with the patient and use iontophoresis or phonophoresis in order to deliver glucocorticoids topically to a specific joint, makes perfect sense. But when you're looking at something like you go to the local pharmacy, you pick up the hydrocortisone 1%, you're going to wrap it on your elbow because you think it's going to help, your patient's not going to get enough drug at the site. The drug's just not going to get into the skin deep enough. And without systemic drug being delivered, just over-the-counter cream preparations aren't going to work. We've talked about inflammatory pains. Now let's talk about neuropathic pains. These are the things that we're going to talk about. The biggest anticonvulsants that we'll talk about will be gabapentin and pregabalin. Again, these are both, gabapentin and pregabalin are structurally related to GABA, but they don't actually bind to the GABA receptor. They actually bind to the A2 delta ligand on calcium channels, which prevents that calcium surge, which causes nerve conduction. So you reduce the calcium-dependent release of prognosis-receptive neurotransmitters and potentially some modulation of calcium channel function overall. And there's even some thought for pregabalin specifically that you actually have some modulation going on there, because it does have activity within the noradrenergic and serotonergic pathways, which are both part of modulation. So that's that fourth part of the pain pathway. Again, these drugs specifically don't bind to GABA. They bind to that A2 delta ligand, and that's responsible for not this GABA receptor. That's not where gabapentin and pregabalin bind. For immediate release, generic gabapentin, initial dosing is recommended between 1 and 300 milligrams 3 times a day. I don't know a lot of folks that tolerate 300 milligrams 3 times a day without being sedated to the point where they're going to sleep pretty much all day. I generally see between 100 and maybe 400 milligrams total. Now that's going to be divided over the course of a day, and generally it's not just going to be once daily. In general, you need to have around 1,800 milligrams of gabapentin orally in order for it to be effective for neuropathic pain. Again, that it kind of depends, because there aren't any real great data that show 1,800 is the cutoff, and if you're under that, it's unlikely to work. But 1,800 is generally shown to be, that's a sufficient trial. Good part is there's no hepatic metabolism, but you do have to worry about your renal function. And I mentioned dizziness and drowsiness, but also ataxia and fatigue can also be a problem with gabapentin. So those patients that already have baseline dizziness, drowsiness issues, or fatigue, this could actually worsen it. Gabapentin extended release would be an option for somebody either where their insurance would cover it, because this is generally considered to be it's still a proprietary branded product. The good part is it's dosed either once or twice a day. And the total daily dose, unlike with immediate release gabapentin, because gabapentin ER, the mechanism behind how it disperses from the tablet, you actually are able to absorb more. So the dose dump that you get from immediate release gabapentin, you actually lose a lot of the drug. So that's why you have to get that 1,800 milligrams that I've kind of been talking about. But for the tablet form of the gabapentin ER, generally it's recommended to have no more than 1,200 milligrams in a day. You do have to look at renal function, and the same overall problems with gabapentin are still problematic with gabapentin ER. And there's a titration right here, which I've already thrown in there too. For pregabalin, initial dosing from the package insert still says between 25 and 150 milligrams up to twice a day. I don't know many people that tolerate more than about 50 twice daily or maybe 50 once a day, and then increased weekly until you get to around 450. I generally don't like going over 450, but I have had a couple of patients that have done a little bit better at 500. I've never had anyone up to 600. If some of you have, we could talk about that at some point if you wished. Renal adjustment is still necessary here. And again, still no concern with hepatic metabolism. And again, the biggest same side effects, dizziness, somnolence. This one also has some peripheral edema. So if you've got patients with heart failure, you might want to just watch them or at least have them be more aware, especially when you start or you increase doses. A couple other drugs, and oxcarbazepine, and I have at the bottom here which ones are not FDA approved. So I'm not going to mention like this one is or is not, but it is listed on the slide. Carbamazepam is still the drug of choice for trigeminal neuralgia. Now, that indication also came out back in the 70s, back when that was pretty much the only drug that they looked at for trigeminal neuralgia. Nevertheless, it still has the indication, but it is not a clean drug. It is a metabolic nightmare drug. And on top of that, you have to worry about aplastic anemia. You have to worry about liver dysfunction. You have to worry about a number of things with carbamazepam. Oxcarbazepine could be used, and I've got some information on here, at least from, it's a little bit better tolerated than carbamazepine, doesn't generally cause nearly the same amount of aplastic anemia. LFT is still potentially a problem, does cause hyponatremia, so it's something, again, to watch for. You're still going to grab labs regardless. Then patients that have had an intolerance to carbamazepine in the past may have an intolerance to oxcarb, but it's really going to depend on what you and the patient want to use. Lamotrigine has some data looking at HIV-associated neuropathy, diabetic polyneuropathy, and even for those people with spinal cord injuries. The problem with lamotrigine, you also run into, you have a number of metabolic constraints that you do have to worry about with cytochrome P450. Also, it can cause Stevens-Johnson's type reactions, especially if you have a patient on something like divalproex or another strong 3A inhibitor drug. Topiramate can also be used. Again, not FDA approved, but has been used for trigeminal neuralgia, migraine prophylaxis, dosing between 50 and 100 milligrams a day. I'm sure some of you are probably aware of Topamax, used to be referred to as Stupamax because it caused patients to be in a fog. Basically, every one of these anticonvulsants has some kind of an effect on neurocognitive function. It causes a decrease in psychomotor reaction time. You have difficulties with learning, memory, executive function, word finding. Maybe I have some neurocognitive. Just kidding. It's just late, and I have 2 kids that are very young. Considerable variance does happen because of age. If you've got multiple anticonvulsants, and I mentioned this without putting it on the slides, but especially if you have patients that are on other highly metabolic drugs, if you have a patient on HIV and they're on antiretroviral therapy, to be very cautious with these drugs, because some of them may actually be inducers, some may be inhibitors. It's really important to take a look at the overall drugs, especially when adding anticonvulsants to a patient's profile, especially if they've got a number of other comorbidities that are already being treated by yourself or by other providers. And all pharmacists should be looking at these regardless when you're taking a look at the patient's profile. All right, let's switch over to local anesthetics. Now, these really work on transduction. So I told you that's that first part in where the noxious stimuli is transmitted its information into the subcutaneous tissue, into the nervous system, and the peripheral nervous system. Local anesthetics work by stabilizing the sodium channel membranes. And if you remember back to physiology, Sodium and potassium are the channels that are responsible for nerve propagation and depolarization. So we're just trying to prevent that from happening. You can use this topically. They can be done intradermally as nerve blocks, pre-procedural. It just kind of depends. There are also a number of different patches which also have a number of different strengths that are also indicated. Specifically, the 5% patch is indicated for the management of postherpetic neuralgias. The thing that I like to talk about when it comes to local anesthetics is there are two specific camps of local anesthetics. There's the lidocaine camp, or the aminoamide agents. Those are listed. But then there are also these amino esters. And unless you work in a hospital, or if you have a clinic and you use a number of different types of local anesthetics, probably going to be using lidocaine or bupivacaine as your primaries. Keep in mind that patients can actually have allergic and anaphylactic types of reactions to either aminoamides or amino esters, but it's more likely that the esters cause those reactions. Also, I threw cocaine on there because it is an amino ester for completeness sake. I talked about lidocaine already. Again, topically, injectable. The patch has a wide variety of percentages available. Generally, you do have to worry about tachyphylaxis with those 5% patches or 4% patches. So you put no more than 3 patches on. The patches can be cut, which is good. The gel doesn't just spill everywhere, and you're able to apply it to the dermatome, or however it needs to be configured to give the patient the best pain control while it's on. So again, it can cause tachyphylaxis if it's left on there for extended periods of time. Let's talk about tricyclics. So every one of these are going to be not FDA approved, but tricyclics have a similar mechanism of action to SNRIs in that they inhibit norepinephrine and serotonin reuptake. Tricyclics specifically work on sodium channel action potentials. That's going to come up when we talk about adverse events. The antidepressant and the neuropathic effects are totally separate. So the antidepressant effects for tricyclics generally takes between 4 and 6 weeks. You'll see neuropathic effects in about 2 weeks. And you use lower doses to work on neuropathic pain than you do for the antidepressant effects. Those sodium channel action potentials are a problem when you think back to your cardiac physiology. Think about those class 1 anti-arrhythmic agents. Those are all sodium channel based. That's why you have to worry about arrhythmias with patients on high doses of tricyclic, especially if it's over like 100 milligrams of amitriptyline equivalents daily. Those patients over the age of 65, just because they can be exquisitely sensitive to shifts in catecholamine or sodium, that could actually cause problems. That's why I threw that on there as well. I have your low doses here. It's for neuropathic pain. Nortriptyline is probably my preferred. Amitriptyline can be used, desipramine as well. I generally go with nortriptyline if I'm going to be recommending it because, and that'll come up on the next slide, but you'll see why. Things to also consider, try to be cautious in those patients that have glaucoma, cardiac disease, at risk for suicide. Does have a black box warning for increased risk of suicidality. And for BPH, again, there are those adrenergic blocking compounds, so that can actually exacerbate BPH. So if you notice, nortriptyline is actually under the secondary amines, nortriptyline, desipramine, and protriptyline. These are going to be better tolerated than tertiary amines. They are just as effective. Nortriptyline is actually the metabolite of amitriptyline, and imipramine actually becomes desipramine. So those two, and that's why I said I like using nortriptyline myself. Really, we don't grab therapeutic drug monitoring. Even in the emergency department, I don't really need to know what dose of tricyclic they're on. I just need to know if they're on a tricyclic. So if we need to reverse or whatever we need to do. Talked about cardiac conduction and cardiovascular disease. Really just a baseline ECG, and then yearly if you're going to be following and monitoring this patient, if you're concerned, I would at least grab a baseline. And if you're not concerned after the baseline, don't worry about it. The orthostatic postural hypotension does come because you do have those effects on norepinephrine. So just make sure you let the patient know, don't start at the top of the end dose, start your dose at bedtime. Make sure you're taking a couple seconds to rise out of bed so you don't fall out of bed. SNRIs are also going to be inhibiting norepinephrine and serotonin uptake. Those again work on that modulation part of the pathway. The dosing is generally higher for neuropathic pain compared to depression. So instead of duloxetine 60 milligrams daily for depression, you're going to need duloxetine at least 60 milligrams daily, and more likely 90 milligrams a day or up to 120 or 60 milligrams twice daily. Withdrawal symptoms can occur with SNRIs or tricyclics. I just mentioned them here because it's very well studied, especially with venlafaxine, that if you just take someone that's at a high dose, and also SNRIs are going to need higher doses for neuropathic pain. That's why I mentioned the withdrawal syndromes here, is because if you just take someone and you stop them, you're going to increase their risk for anxiety, irritability, headaches, paresthesias. And again, just be careful with liver dysfunction. Get your baseline labs and keep monitoring as appropriate, or as the specialist that's talking to them with their liver dysfunction is working with your patient. Duloxetine is the one that probably everybody's most familiar with. It's FDA approved, fibromyalgia, low back pain, and for diabetic polyneuropathy. It's going to generally be between 60 and 120 milligrams, as I mentioned. Venlafaxine, not FDA approved, but we're targeting a dose of around 225 milligrams a day. You do have to renally and hepatically dose adjust, and you do have to be at least aware that you can cause some blood pressure changes with venlafaxine. Again, you still have that norepinephrine serotonin activity. Milnacipran's been on the market for quite some time as well. This is specifically for fibromyalgia. You've got this, it's got a titration schedule that I've already got listed out here. Most patients tolerate that 50 twice daily. I have had some patients that have reported not being able to tolerate going all the way up to 100 twice daily, but 50 twice daily seems to do fairly well. And again, you're looking at that 2 to 3 week period, just like with tricyclics, in terms of like for you to get your full effects. Now, tricyclics and SNRIs, both of those actually mention serotonin, right? So I do have to at least mention serotonin syndrome. Do I really think this happens very often? Not generally, but is it reported? Yes. Is it a real possibility? Yes. Is it also just a clinical diagnosis by exclusion? Yes. But what are the things that are involved in serotonin syndrome? Well, that can be mental status changes, autonomic hyperreactivity, and the biggest one here is probably the diaphoresis. So if you've got that patient, they're sweaty, they're tachycardic, they're hyperthermic. That patient that's hot and they're soaking wet and their heart's just beating out of control, that's going to be much more likely for me to think serotonin syndrome, as opposed to some other type of cardiovascular event with diaphoresis and tachycardia. Well, I go like potentially for acute myocardial infarction there, or an NSTEMI. But the hyperthermia is the one that really gets you, as well as the tremors, the muscle rigidity, and the clonus. Those two sets of things are probably the biggest things to push you towards that maybe this could be serotonin syndrome. And again, really, it's a clinical diagnosis by exclusion, which if you're interested, there are the Hunter criteria here. This actually tells you the likelihood that this patient's experiencing serotonin syndrome. So if you notice, what are the biggest things that they have noted here? clonus, diaphoresis with clonus, ocular clonus with diaphoresis, tremor and hyperreflexia, hypertonia, and the temperatures. So again, you're still going to have to get a lot of labs just to rule out everything else, but these are the things that should, plus the fact that they're on a serotonergic acting drug. FYI, as in terms of opioids, fentanyl also has some serotonergic activity. I throw that out there for your information. I'm letting you know. I'm not going to go into capsaicin 8% too much. This is considered to be a counter irritant, but what I will say is that it is in a couple of different guidelines in terms of for its indications for polyneuropathy. This is one of those things where it's applied in the clinic by the provider, and you can use between 1 to 2 or 4 patches. They're applied in the clinic, and you are going to monitor them while they have the patch on for the hour, and then you're going to remove the patches. You're going to put the cleansing gel on there to make sure you get all the capsaicin off, and you're going to make sure that everybody was wearing their appropriate PPE and washes their hands, because if you've ever had the misfortune of making really hot chili, and I've done that once or twice, and then you put your hands next to your face because you're not paying attention, and you pay for that. And that's with using food grade. This is 8% pharmaceutical grade. This could cause a lot of pain for a while. So it's really important to make sure that the providers in the clinic as well as the patients are aware of this. And after the patches are applied, the patch application sites are still going to hurt for quite some time. So make sure the patient's aware of that too. Let's talk about neuropathic pain, because we've talked a lot about this. So we've got tricyclics and SNRIs, and specifically the gabapentin and pregabalins. Those are initial treatment, except for trigeminal neuralgia, which again would be carbamazepam still. These are the NICE guidelines out of the UK that I'm referring to. They only use tramadol if it's absolutely necessary. And again, capsaicin creams, they didn't really go into the patch, but the cream at least, for people with localized neuropathic pain that don't want those oral treatments. Muscle relaxers, and we're almost done, and I promise you we'll get you out of here. Muscle relaxers, when I'm thinking about that, I'm thinking spasticity, which is generally defined as upper motor neuron dysfunction, hypertonicity, and voluntary jerks. And generally these muscle relaxants, I'm going to focus on 2 of them for multiple sclerosis, cerebral palsy, spinal cord injuries, or even for acute muscle spasms, which there's a lot of drugs that are in that anti-spasmodic category, and I'm going to get into that in a second. Anti-spasticity agents, the ones that are much more likely to be long-term prescribed for a patient, would be baclofen and tizanidine. Baclofen looks and sounds kind of like GABA, and it actually is similar to GABA. It does cause a muscle relaxation and analgesic effects, a little bit reduction in substance P. And again, 5 to 10 milligrams 3 times daily. It's increased risk of somnolence and potential for seizure activity. Also, this is where your baclofen pumps come in, but that's really outside of the scope specifically for pain management. Tizanidine is probably one of my favorites. It's got alpha-2 receptor activity. You're actually decreasing your alpha motor neurons, which is part of a separate part of the autonomic nervous system, not necessarily your fight or flight response. Doesn't have any effect on the spinal cord reflex, and it does have a little less antihypertensive effect than clonidine, but it's not devoid of it. So tizanidine, especially if you've got patients that are already not well controlled on blood pressure, probably I'd start with baclofen as opposed to tizanidine. And again, starting between 2 and 4 milligrams 3 times daily, twice daily, 3 times daily. You do have to worry about liver toxicity with this one. It's something that I think is a little bit underutilized. Most everybody's aware of antispasmodics. These are only indicated for about a month of use. So this includes things like cyclobenzaprine, metaxalone, methylcarbamol, and each of those has their own set of issues, which I have structured right here. So cyclobenzaprine, keep in mind, cyclobenzaprine, if you look at the molecule and compared it to amitriptyline, there's only one carbon tail in difference between cyclobenzaprine and amitriptyline. So no surprise that it causes sedation, somnolence, dry mouth, all of those things that you would see from amitriptyline. Methylcarbamol, there's not a lot of evidence. Orphenadrine does have some sodium channel blockade. You might want to be a little bit careful in patients with severe arrhythmias. I have carisoprodol on here. I really only think of that as a drug. That's Soma is really just only used for those patients that to not put too fine a point on it are less likely to want the medication for its analgesic effects and more for their secondary gain effects. That's just been my personal stance on carisoprodol and why I try to avoid using it at all costs. I'd rather use diazepam, which is a known benzodiazepine, over carisoprodol. And I am aware of the fact that diazepam is not FDA approved for anti-spasticity or for anti-spasmodic effects. And it does have its own set of problems and its own metabolic issues, but I have had patients that have responded well to it. Metaxalone, still expensive, even though it's been generic for some time, but still useful. When it comes to musculoskeletal pain management, acutely for non-low back injuries could be treated with topical non-steroidal, so topical diclofenac, for example, plus or minus menthol as a first-line recommendation. For acute pain from non-low back pain, musculoskeletal injury with oral non-steroidals, or you could do acupuncture, transcutaneous nerves, TENS units, or oral acetaminophen. And if you needed to use opioids, you could use something like tramadol as an initial line agent. And that's out of the Annals of Internal Medicine last year. So in conclusion, we've looked at a lot of different non-opioids, and I've hopefully given you the mechanism behind them, how they work, where they work, why they would be effective for your patient under specific conditions, and what patients would be appropriate and also not appropriate for each of these drugs. Keeping in mind that comorbid disease states really can have an impact, especially when there's something that could cause a severe outcome, like if they have cardiovascular disease, if they have a history of GI bleeds and with non-steroidals, lots of things. So it's taking the whole patient into consideration when you're trying to manage their pain with these non-opioids. And there we go. Really that early? I guess so. All right. So at this point, I'm going to be answering questions along with Dr. Botros, and then we will be concluding the webinar. Again, click on the Q&A button at the bottom of the screen and type in your questions, and I will ask those to both Dr. Botros and myself. Let's see. Is anyone using other fibro treatments for long COVID like gabapentinoids or SNRIs?
Yeah, so the answer is obviously it's anecdotal, no trials, but there are people who are using these types of medications and trying to treat long COVID along the lines of something similar to fibromyalgia. Again, no real formative trials yet.
Let's see. It's looking like a lot of these were probably with the last presenter regarding Medicare, and so I'm just gonna If you hear that, that is my 1-month-old son. His name is Tyler. He is very upset because he is being switched to a new formula. So if you hear him, I apologize. I haven't heard of going up to 120 milligrams of Cymbalta. Is that a study or from personal experience? So the 120 milligrams of Cymbalta, Dr. Batros, have you used Cymbalta specifically in your neuropathic practice? Or I know you do anesthesia, but have you used doses exceeding 60 milligrams daily?
Yeah, I mean, I've gone up to 90 milligrams on some patients with chronic pain, I rarely go up to 120, but 90 tends to be my limit. I find that for a lot of the SNRIs and the alpha 2 delta ligand calcium channel agonists, that they, how do I put this? Going up to the maximum dosage doesn't always give you the greatest, and Thomas, please let me know how you feel about this.
Oh, you're fine.
But like, I don't feel that necessarily pushing to the limit gives you the best clinical efficacy. I'll give you a good example. When you look at the Cochrane reviews, let's use pregabalin as an example. You can go up to 600 milligrams on a day on pregabalin. We don't tend to go higher than 300, and I'll explain why. If you look at the number needed to treat versus the number needed to harm, the number needed to treat at 300 milligram dosage Q day for pregabalin is something like, if I remember correctly, it's around 8. And then the number needed to harm is something like around 17 or 18. And when we say number needed to harm, we're talking about the number of, it's not necessarily leading to morbidity, but leading to side effects that lead to discontinuation of usage of the drug, right? So you've got a therapeutic window of something between 8 and 17. However, if I increase that dosage from 300 milligrams of pregabalin to 600 milligrams, what do I do to the number needed to treat? It goes down, right? The number needed to treat goes from 8 to 5. However, the number needed to harm goes to something like 9. So now my therapeutic window is 5 to 9. So I would rather be in the larger therapeutic window than the narrower therapeutic window, if that helps sort of, answer that.
Absolutely. And I would actually echo exactly what you were talking about. Normally 60 to 90 milligrams is what I've generally seen. 120, if you're getting to that point. And to answer your question, there were some like small trials looking at 190 milligrams daily and 120, but those were a very small number of people that actually were able to tolerate that 120 milligrams daily and complete the trial. And so that's where the problem came from, but they still looked at those patients to see whether it would or would not work. So in general, 120 is probably going to be way too much. It's also the same with going to 3,600 of gabapentin. Could it be used, and could you do 900 milligrams 4 times daily? Sure, but are you probably going to be in a fog most of the time and asleep behind the wheel or everywhere else? A high likelihood too. What would be your recommendation for peripheral neuropathy after chemotherapy? So that one's going to, Michael, do you have one on that one?
Well, it's very difficult to treat chemo-induced peripheral neuropathy, especially the cisplatin, induced peripheral neuropathy. That's really difficult. We did a study when I was at Washington University where we tried giving intravenous lidocaine to patients who were treatment resistant on oral medications to peripheral neuropathy from chemo. And I think it either is going to be published or has been published just recently. And unfortunately, even intravenous lidocaine didn't necessarily provide the level of relief that we were hoping for. But please go ahead, Thomas.
Honestly, mine's been fairly limited in the management of outpatient chemotherapy, but that's generally looking at the gabapentinoids, looking at the local anesthetics, and that's in some of those patients, maybe trying some of the gabapentins, but for the most part, I haven't had enough experience really to be able to relate that one.
Remember, of course, for who asked the question, when you have when you have treatment-resistant patients, what I mean, the term may be misleading, but essentially just they're not finding efficacy with a number of different medication subtypes. You might want to think outside the box. And so I mention this because I've treated a number of these patients with spinal cord stimulation. So people, with peripheral vascular disease, like in Europe, for example, peripheral vascular disease is one of the indications for a spinal cord stimulator. Peripheral neuropathy or diabetic polyneuropathy can be used successfully in patients who might not have had good success. And I'm talking about patients who obviously are really suffering from these medications. It can be really life-changing, and unfortunately no medication has provided relief. You may want to think about something like spinal cord stimulation. That's an option, is what I'm trying to say.
That's a good point. Seeing much else? Make sure I'm not missing any.
Topical.
Do you use topical nonsteroidals on top of oral nonsteroidals? Is topical nonsteroidal use okay prior to surgery? So the topical nonsteroidal plus an oral nonsteroidal, it seems like you're already kind of, if you're using the oral nonsteroidal, that's going to get you systemic concentrations. So it's going to still get to the bone, it's going to still get to the joints, it's still going to get to caps, it's going to get to all the places you want it to get, but it's still going to get to those places you didn't want it to get. To use a topical with an oral agent, there are some trials that have looked at the combination of the two to see if you can get a little bit better effect. But in general, all it showed was that the oral agents that were given, as opposed to the placebo orals, you had more GI complications, you had more adverse events in those patients that were taking both the topicals with the oral agents. Did you have any other thoughts on that one, Michael?
No, I agree.
Okay. Making sure I don't have anything else here. All right. Well, if there's nothing else, I want to thank everybody on the panel for being able to join us for this PAINWeek Premiere webinar. You will all be receiving a link by the end of next week to receive your CE and CME credits. Please make sure you check your junk and spam folders. If you've not done so, please register for the PAINWeek Digital All Access, PAINWeek 2022, or PAINWeek Plus. If you do so tonight, you'll even save $100 by using code PWP when you register. If you are interested in more than one of these PAINWeek Premiere webinars, our next one will be this coming Saturday. And Dr. Batros, are you and I both at that one?
I don't think so. At least I don't think I'll be there. I'm going to be doing a live presentation a little bit later next month.
I see. Well, I will be there on the 9th, and then I will see many of you there. And if I don't see any of you between now and then, please give us a call if you have any questions. It's 973-415-5100. And again, everybody have a great evening.
Thanks.
Thanks. Good night.